Did you know that even at the very highest level, with all the cutting edge sports science and dedicated medical teams, elite track and field athletes still suffer injury rates of up to, what, 76% every single season?
It's quite startling, isn't it?
It really is. And here's the kicker. Most of these aren't dramatic collisions or anything like that, but sort of insidious overuse issues that build up slowly.
Exactly.
We're talking about forces like your hamstrings having to counteract 8 times your body weight during a sprint. I mean, it just makes you wonder if even these peak physical specimens pushing the absolute limits of human performance struggle so profoundly with managing stress and recovery. What can we learn from their challenges about handling the relentless demands of our own professional
Yeah.
lives?
It's a very relevant question.
Welcome to the Deep Dive, where we take your source material articles, research papers, expert notes, whatever you send us, and we really unpack it, trying to extract the most important nuggets of knowledge or insight to help you cut through the noise and get well-informed quickly.
A valuable service.
Today, we're plunging into a pretty technical source, actually, focused on the prevention and management of track and field injuries. It's a realm where pushing the body to its absolute limit is, well, it's the goal, isn't it?
It is indeed.
And understanding breakdown and recovery isn't just academic, it's really essential for survival in the sport. Joining us is Prof. Mo Imam, who has this remarkable ability, I think, to synthesize complex information and illuminate why these specific details truly matter, offering lessons that resonate far beyond the track or the stadium.
Well, I'll certainly try my best to connect those dots.
Right then, let's get straight into it. Professor, the source material makes it abundantly clear. Overuse isn't just a cause of injury in track and field, it seems to be the dominant one, cited in up to, 96% of cases?
That figure is astonishingly high, yes.
Given the incredible level of knowledge and support available to these athletes, why does overuse remain such a pervasive problem? And what does its prevalence really tell us about the fundamental demands of the sport itself?
That's precisely where we need to start, because it really highlights this inherent tension in elite performance, doesn't it? The source confirms that despite decades of advancement in our understanding of biology, physiology, biomechanics, you name it, overuse pathologies remain remarkably high.
Still a major problem.
Absolutely. The core issue, as the document implies, is this relentless pursuit of supercompensation.
Yeah.
The process where the body adapts and actually becomes stronger after recovering from a training stimulus.
Right, that's the goal of training.
Exactly. So to achieve peak performance, athletes simply have to train at intensities and volumes that constantly challenge their physical limits. Now, while the theoretical ideal is, of course, never to train beyond what the athlete can safely endure, the reality of competitive demands means they are consistently pushing very close to that line. And this constant high-level stress, applied repetitively across training cycles, well, it accumulates microdamage in tissues. It's the cumulative effect of thousands upon thousands of repetitions, jumps, sprints, whatever it might be, rather than a single traumatic incident that leads to the vast majority of injuries in this environment.
So it's that drip, drip, trip effect.
Precisely. What it tells us is that the sport fundamentally requires pushing physiological boundaries, and even the most perfect planning struggles against the sheer volume and intensity of the necessary training load over time. And I think this is a critical lesson in any field where performance demands are high, that cumulative stress is often the silent killer, not just the sudden crisis.
That idea of cumulative stress building up over time is, yeah, it's powerful. And it brings us nicely to the types of injuries we actually see. While we often hear about the dramatic, explosive injuries, a big hamstring tear or an Achilles rupture, the source spends considerable time detailing chronic conditions, things like Achilles tendinopathy or what people commonly call shin splints. What's fundamentally different about how these chronic issues develop compared to the acute ones, and why does the source suggest the chronic side is often poorly managed?
This is a really crucial distinction that the source makes quite precisely. Acute injuries, like muscle tears or ligament ruptures, they often have a very sudden onset, typically occurring during those high-force explosive movements. Think about the powerful drive phase of a sprint or the landing from a jump.
Big impact moments.
Exactly. These are moments where the tissue load suddenly exceeds its immediate tensile strength, leading to, well, failure. Chronic conditions, on the other hand, develop much more gradually. They are the direct result of repetitive microtrauma, where the rate of tissue damage consistently exceeds the rate of tissue repair over days, weeks, or even months. Tendinopathies and medial tibial stress syndrome, MTSS, or shin splints, fall squarely into this category.
Right.
Now, the source highlights a particularly important nuance regarding tendons. It defines tendinosis as a chronic, degenerative condition of the tendon mid-substance caused by repetitive microtrauma. And here's the really vital part. Histological studies, looking at the tissue under a microscope, rarely show classical inflammatory changes in chronically painful tendons.
Oh, that's interesting. So it's not necessarily inflamed.
Often not, in the classical sense. This challenges the common assumption that these issues are primarily inflammatory. In contrast, tendinitis is defined as a painful inflammatory process mediated by cytokines. This means many chronic tendon pains aren't really about inflammation needing anti-inflammatories, but more about the tissue structure itself, breaking down, degenerating, which requires a completely different management approach focused on stimulating repair and adaptation.
That changes everything in terms of treatment, presumably.
It certainly should. The source specifically notes that MTSS, shin splints, is often poorly managed, suggesting this is linked to a lack of contemporary understanding of its underlying pathology. It involves a stress reaction in the tibial bone and the surrounding fascia, not just simple muscle soreness or some uniform inflammation. Mismanaging these chronic conditions often stems from applying treatment models designed for acute inflammation to problems that are actually degenerative or related to bone stress responses. For you, perhaps thinking about professional strain, this is a bit like trying to solve burnout with just a few days off when the underlying issue is a chronic, systemic problem with workload and lack of recovery. It's the wrong intervention for the actual pathology.
That distinction, degeneration versus inflammation and chronic tendon pain, that is a real aha moment, isn't it? It moves beyond just, oh, it hurts, it must be inflamed. My third rapid-fire question touches on these foundational principles of athletic adaptation mentioned in the source, supercompensation and heterochrony. How are these concepts woven into the fabric of injury risk and recovery?
These are absolutely fundamental, yes, to designing effective training and, crucially, for avoiding injury. Supercompensation, as we touched on earlier, describes the body's adaptive response to training stress. When you apply a training load, you temporarily reduce the body's capacity to cause fatigue. With adequate recovery, the body not only returns to its baseline, but ideally rebuilds stronger than before. That's the supercompensation bit. It's the goal of every single training session and cycle.
Makes sense.
However, the source introduces heterochrony, which is the critical complication. Heterochrony essentially means that different physiological systems within the body recover and adapt at different speeds. Muscle tissue might recover from a hard session relatively quickly, perhaps in 24-48 hours.
Okay.
But denser, less vascular tissues like tendons and bones, or complex systems like the nervous system or the endocrine system can take much, much longer days, even weeks sometimes, to fully recover and adapt.
So everything doesn't bounce back at the same rate.
Precisely. And the connection to injury risk is clear. If you impose the next high-intensity training stimulus before those slower recovering systems have completed their recovery and adaptation cycle, you basically prevent them from supercompensating. Instead, you're just layering new microtrauma onto existing unrecovered damage.
Right, that cumulative stress again.
That is the very definition of the cumulative stress that leads to overuse injuries, like tendinosis or bone stress reactions. Effective training periodization, structuring training and recovery over time is essentially the art and science of managing load while respecting the heterochrony of adaptation across all the body's systems. It's about timing subsequent stresses based on the recovery rate of the slowest adapting tissue, ensuring everything catches up eventually. It's a really complex balancing act.
That framework of adaptation happening at different speeds across the body is incredibly insightful, I think, both for athletes and, frankly, for anyone pushing boundaries in demanding fields.
Let's take a deeper dive now, really unpacking the science of breakdown and how we understand it, maybe starting with the sheer scale of the problem. You gave us the prevalence number earlier, but let's just underline how common injuries really are.
Indeed, the numbers from the source are compelling. You really can't ignore them. We're looking at injury prevalence rates between 61% and 76% at the national level per season.
Per season. So almost 3/4 might get injured in a year? That's right. 3/4 of elite athletes are likely to experience an injury in any given year. The incidence rate is also high, reported as 3.6 to 3.9 injuries per 1,000 hours of practice.
Wow. Can you put that in perspective?
Well, for someone training, say, 20 hours a week, that could mean an injury cropping up every few weeks or months on average. And as we've sort of hammered home already, the vast majority, 72% to 96%, are due to overuse.
Hmm.
These figures aren't just statistics. They represent lost training time, missed competitions, significant physical and psychological burdens for the athlete. They really underscore that despite best efforts, the intensity and volume required by track and field push athletes constantly towards the brink of overuse injury.
It's striking just how pervasive it is. So let's zoom in on the tissues themselves. You gave us that critical distinction between tendinosis and tendinitis earlier, which was fascinating. But let's go a bit deeper into how tendons specifically function and what actually happens when they're subjected to this relentless load beyond just that lack of inflammation, maybe.
Certainly. The source describes tendons as remarkably robust structures, primarily composed of these parallel collagen fibers, mostly type pyocollagen arranged in fascicles, with specialized cells called tenocytes dotted amongst them. They function not just to transmit force from muscle to bone, obviously allowing movement, but also to store and release elastic energy, which is particularly crucial in running and jumping. Think of the Achilles tendon acting like a powerful spring during your gait.
Right, like a rubber band.
Exactly, a very sophisticated one. Now, when subjected to chronic repetitive loading that exceeds their repair capacity, tendons undergo structural changes. This is the pathology of tendinosis described in the source. Instead of nice, neat, parallel collagen fibers, you start to see disorganized, thickened tissue, increased cellularity, though importantly, not inflammatory cells, and sometimes changes in the actual type of collagen produced.
So the structure itself
Yeah.
changes.
Profoundly. This altered degenerative tissue is mechanically inferior to healthy tendon. The source provides some pretty stark evidence of the consequence. A prospective study cited showed that 28% of individuals with sonographically, that's via ultrasound imaging detectable Achilles degeneration, went on to suffer spontaneous ruptures within 4 years.
28%, that's huge.
It is. It illustrates that this chronic, non-inflammatory degeneration isn't just about pain. It fundamentally weakens the structure, making it significantly more vulnerable to catastrophic failure under high, often asymmetric loads. Examples from track and field cited in the source include Achilles tendinopathy, which experiences some of the highest loads in the body, up to 10 times body weight perhaps, and chronic patellar tendon overload, very common in jumpers.
That statistic about the increased rupture risk is, well, it's chilling, really. It makes the chronic degeneration seem far more serious than just a bit of persistent pain. What about bone? We tend to think of bone as solid, immutable, but it's constantly remodeling, isn't it? How does it handle repetitive impact?
That's right. Bone is a highly dynamic tissue, constantly being broken down by cells called osteoclasts and rebuilt by osteoblasts. This remodeling process is very sensitive to mechanical ply load, and bone adapts by becoming stronger. However, just like tendons, there's a rate limit.
Okay.
The source explains that under high-frequency repetitive stress, like distance-running osteoclast activity, the breaking down bone part can temporarily outpace osteoblast activity, the building new bone part. This leads to a transient state of local bone weakness and the accumulation of microscopic cracks or microfractures within the bone matrix itself.
Tiny little cracks we don't even notice.
Initially, often yes. These micro-injuries trigger a biological response, often detected on an MRI scan as bone marrow edema, essentially fluid accumulation within the bone marrow as part of this reactive process. This is the stress reaction, the initial phase of the overuse bone injury spectrum.
Right.
If the repetitive load continues without sufficient rest to allow that osteoblast activity to catch up and repair the microfractures, these cracks can then propagate through the cortex, the hard outer layer, resulting in a visible break, a stress fracture.
So a stress fracture isn't a sudden event in the bone. It's more like the end stage of this process of cumulative microdamage that started as a stress reaction.
Exactly. It's a spectrum.
So bone stress injuries are a spectrum, not just a single event. Fascinating. And ligaments and cartilage, how do they fit into this picture of overuse?
Well, ligaments are dense connective tissues, primarily providing joint stability. They also undergo phases of healing, inflammation, proliferation, and remodeling. But the source notes that intra-articular ligaments, those completely inside a joint capsule like the anterior cruciate ligament, ACL, have a limited healing capacity. This is largely due to their poor blood supply and the specific environment of the joint fluid.
So they don't heal as well if they're inside the joint.
Generally, no. While traumatic ACL ruptures are common in many sports, they are less frequently about the overuse injury seen in track and field compared to muscle, tendon, or bone. Although you could argue that chronic laxity from repeated microstress could theoretically contribute to instability over time.
Okay. What about cartilage?
Cartilage, specifically articular cartilage covering the joint surfaces, is a very specialized tissue made by cells called chondrocytes that resists compression and provides that smooth, gliding surface in joints. Critically, it has a very limited capacity for repair.
Right, I've heard that.
The source mentions that under chronic abnormal loading or repetitive impact, articular cartilage can degenerate, leading ultimately to osteoarthritis. What happens is the chondrocytes in osteoarthritic cartilage start producing altered collagen, shifting from the usual strong type 2 collagen to less resilient type I, which reduces the cartilage's ability to withstand tensile stress and leads to softening and eventual wear and tear. So again, this highlights how tissues with impaired healing responses are particularly vulnerable to chronic degeneration from persistent load.
Understanding how each of these tissues responds differently to chronic stress is clearly vital. And as you pointed out earlier, the specific forces and movements of different events seem to concentrate injuries in specific areas. Can you elaborate a bit on some of those key location-based injury patterns the source identifies?
Absolutely. The demands of the specific discipline really dictate the injury hotspots. In disciplines characterized by high force and explosive movements, so sprints, hurdles, jumps, the majority of injuries occur in the thigh muscles, particularly the hamstrings.
Ah, yes, the hamstrings.
Indeed. The source highlights that hamstring muscle injuries account for around 17% of all injuries in track and field and represent the highest proportion in these speed and power-focused disciplines. This is directly linked to their crucial role in powerful acceleration and deceleration, and the immense eccentric forces that's lengthening under load they must counteract during the swing to stance transition in sprinting. Forces which, as you mentioned, can reach approximately 8 times body weight.
8 times.
Yes. The length and architecture of the muscle fascicles within the hamstring are even noted as relevant factors in injury risk.
Wow. And what about the endurance side?
Conversely, in endurance events like middle distance, long distance running, and the marathon, where the load is lower per step but vastly more repetitive, we see a higher prevalence of injuries like Achilles tendinopathy and medial tibial stress syndrome, MTSS, shin splints.
The classic runner's complaints.
Exactly. These are the archetypal gradual onset overuse conditions. The sheer volume of steps and the repetitive eccentric loading on the Achilles tendon during push-off, or the repetitive bending load on the tibia, are the primary culprits. And as we mentioned, MTSS is specifically pointed out as often being poorly managed, perhaps due to a historical lack of clarity on its exact pathology and the complex interplay of biomechanical factors involved.
It makes intuitive sense, though, doesn't it? That high force breaks muscle, while high repetition sort of grinds down bone and tendon over time. When these issues do arise, how does the diagnostic process unfold according to the source? Is it just a matter of getting a scan?
Well, while imaging definitely plays a vital role, the source makes it quite clear it's part of a broader process, always beginning with a thorough clinical examination. The athlete's history, the pattern of their pain, and a good physical assessment provide the initial roadmap.
So TACAN testing first.
Absolutely. Then imaging techniques like MRI and dynamic ultrasound are crucial for confirming the diagnosis and importantly for assessing the specific nature and extent of the tissue changes. For tendinopathy, for instance, imaging can help differentiate between thickening and degeneration versus true inflammation, though the source rightly cautions on relying solely on imaging for inflammation.
Right.
For bone stress injuries, MRI is fantastic because it can reveal the subtle bone marrow edema of a stress reaction long before a cortical fracture might be visible on a standard X-ray. Ultrasound can also be useful for dynamic assessment of tendons or looking for potential nerve entrapments.
Are there areas where the diagnosis is particularly tricky?
Yes, the source points out a few. Lateral hip pain, for instance, often gets lumped together as greater trochanteric pain syndrome, or GTPS. But this can actually stem from various issues, including tendinopathy of the gluteus medius or minimus muscles, trochanteric bursitis, or problems with the iliotibial band, ITB. Distinguishing between these requires careful clinical assessment and often quite targeted imaging.
So it's not always straightforward.
Not at all. Another example given is a femoral neck stress fracture. The symptoms can be quite vague, maybe just some groin or hip pain with activity, and initial x-rays are often completely normal. This demands a high degree of suspicion from the clinician, especially in a distance runner, often necessitating an early MRI. So it really underscores that diagnosis, particularly with overuse conditions, is often an iterative process combining clinical findings with appropriate imaging, not just relying on a single scan result.
Right, we've mapped the landscape of the problems, their prevalence, their nature, where they tend to hit hardest. Now let's shift focus a bit towards the solutions. How do we manage these injuries once they occur? And perhaps more importantly, how do we proactively try to prevent them? Starting with management, is there a general philosophy the source outlines for tackling these diverse tissue issues?
The core philosophy, as you can infer from the source, is really about respecting the biological properties and the inherent healing capacity of the injured tissue, while actively facilitating recovery and adaptation. Conservative treatment, which involves initial rest, modifying activity to reduce load on the injured area, and a structured physiotherapy program, is the primary approach for most overuse injuries, and indeed many acute injuries too.
So physio first, generally.
Generally, yes. However, as we touched on earlier, surgery is indicated for specific situations. Things like complete tendon or ligament ruptures, a full Achilles or ACL tear, for example, displaced fractures, or severe chronic conditions that simply haven't responded to extensive conservative management. Think about persistent femoroacetabular impingement, FAI, causing cartilage damage, or severe chronic GTPS that just won't settle.
Okay, so surgery for the big stuff or the really stubborn cases?
That's a good summary. The source provides examples of surgical interventions, like ACL reconstruction using grafts, various tendon repair techniques or procedures like tendon transfer or tubularization to reinforce damaged tissue, bony procedures to correct issues like FAI, where the bones of the hip joint don't fit together quite correctly, or decompression surgery for nerve entrapments.
And recovery times vary hugely, I imagine.
Hugely. While specific return to sport timelines vary massively depending on the injury and the procedure, the source mentions UCL reconstruction in the elbow, often seen in throwing sports, typically takes 6–10 months as an example of a complex ligament repair recovery. The underlying principle is the same. Clear protocols are followed based on the biology of tissue healing.
So it's about matching the intervention to the specific problem, and rehabilitation is obviously central to both conservative and post-surgical management. What does the source emphasize as the key principles of effective rehab? Is it just about doing exercises?
It's much more than just exercises, though they are crucial. Rehabilitation is presented as a structured, multi-phase process. It typically begins with an early phase focused on controlling pain and swelling, maintaining active range of motion within tolerance, and initiating very controlled low-level loading of the injured tissue. The goal isn't complete immobilization usually, but protecting the injury while gently initiating the healing response through carefully managed stress.
So gentle stress early on.
Exactly. This then progresses to a middle phase, where the focus expands to restoring general strength, stability, and coordination, often incorporating low-impact cardiovascular training to maintain fitness levels.
Right.
The later phases then become increasingly sport-specific. This involves drills that mimic the actual movements and forces of the athlete's discipline, a gradual return to practicing with a team or squad, and eventually a carefully phased return to full competitive sport. The overarching principle, really underscored throughout the source's discussion of tissue adaptation, is optimal loading.
Optimal loading. Tell me more about that.
Rehabilitation is essentially a continuous balancing act.
Yeah.
You need to apply enough mechanical stress to stimulate tissue healing, strengthening, and adaptation, but not so much that it causes pain, setbacks, or worse, re-injury. This requires really careful monitoring of the athlete's response, how they feel, how the tissue reacts. The source hints at methodologies for this, such as monitoring training load ratios, maybe like the concept of the acute to chronic workload ratio, although it's not detailed explicitly to ensure gradual, safe progression.
Yeah.
And crucially, significant emphasis is placed on proprioceptive and neuromuscular training, particularly after joint-related injuries or those affecting stabilizing muscles. This is vital for restoring movement control and significantly reducing the risk of re-injury down the line.
Optimal loading, finding that sweet spot between too little and too much stress that resonates strongly with managing workload in any demanding profession, doesn't it? Getting someone back to full competitive sport, though, that sounds like a really high-stakes decision. The source suggests that relying solely on imaging at that point can be misleading. Why is that? And what other factors are critical for making that return to sport decision?
Yes, this is perhaps one of the most counterintuitive but really critical insights from the source. The document explicitly states that imaging is not recommended for making the final return to sport decision.
Really? Not even an MRI?
Not as the sole basis for the decision, no. The reason is fascinating. Structural changes visible on imaging. Things like increased signal intensity, which might indicate residual edema, or altered tissue structure in muscle injuries, Or bone marrow edema in stress reactions can persist for months after an athlete has clinically recovered, is completely pain-free, and has regained full function.
So the scan might look bad even if the athlete feels fine.
Exactly. Moreover, the source points out that bone marrow edema, often seen in stress injuries, can even be present on MRI in perfectly asymptomatic runners. This means a bad-looking scan doesn't necessarily correlate with functional capacity or the actual risk of re-injury once clinical recovery is complete. Relying solely on imaging would keep athletes sidelined unnecessarily long.
Okay, so what do you rely on then?
Instead, the source champions a multi-criteria approach, referencing frameworks like the START framework that stands for Strategic Assessment of Risk and Risk Tolerance. This involves a holistic assessment by the whole medical team considering three primary domains.
Right.
1. Health risk. What is the current state of tissue healing? Are there still any clinical signs or symptoms like pain, swelling, limited range of motion? How do the functional tests look? Strength, balance, sport-specific movements?
Makes sense.
2. Activity risk. What are the specific physical demands of the athlete's sport and their particular event? How well can they protect the previously injured area during competition? And crucially, what is their psychological readiness, including things like fear of re-injury?
Ah, the mental side.
Absolutely critical. And 3, risk tolerance modifiers. This acknowledges the external pressures. Is it the Olympic final versus an early season minor competition? Is there pressure from coaches, agents, sponsors? The decision isn't made in a vacuum.
Right, context matters.
Immensely. Psychological readiness is specifically highlighted as a major factor influencing successful return. An athlete who is functionally ready, but perhaps terrified of re-injuring themselves, is much less likely to perform well or even stay healthy in the long run. So the return to sport decision is this complex negotiation, balancing biological recovery, functional capacity, psychological state, and external pressures, consciously assessing the level of acceptable risk for that specific situation.
That multifaceted decision-making process, weighing internal readiness against external pressures and risk tolerance, that feels incredibly relevant to high-stakes decisions in pretty much any field, actually. Let's shift gears completely now to prevention. If overuse is the primary culprit, as we've established, how does the source suggest we get ahead of it? Is there some kind of magic bullet prevention program out there?
The source frames injury prevention, not as a simple fix, but as a really multifaceted challenge. It outlines a systematic approach, referencing frameworks like the Van Mechelen four-step model. First, you establish the extent and severity of the problem. Second, you identify the causes and the risk factors. Third, you develop preventative measures based on that understanding. And fourth, you rigorously evaluate whether those measures are actually effective.
A scientific approach.
Exactly. But here's a crucial and perhaps slightly surprising point from the source. Currently, there is no high-quality published evidence, specifically from randomized controlled trials, which are the gold standard for evaluating intervention efficacy, proving the effectiveness of specific injury prevention programs specifically in track and field.
Oh, really? So all those prevention exercises might not actually work?
It doesn't mean prevention efforts are futile, not at all.
No.
But it indicates the complexity of the issue and the lack of definitive evidence for any single isolated program being the answer for track and field athletes. We don't have that magic bullet yet.
Okay, so what is the recommended approach then?
Therefore, the necessary approach, as advocated by the source, needs to be global, multimodal, and multifactorial. This means prevention must address numerous potential contributing factors simultaneously.
A holistic view.
Precisely. It includes optimizing physical conditioning, meticulously managing training, load balancing volume, intensity, frequency, and crucially, recovery refining technical movement patterns, because even seemingly small inefficiencies repeated thousands of times can lead to overuse. It also involves promoting healthy lifestyle factors like sleep and nutrition, addressing psychological aspects such as stress management and athlete well-being, ensuring appropriate equipment like footwear or even track surfaces, providing consistent access to qualified medical and sports science support, and fostering sustained engagement and communication among all the stakeholders, the athlete, the coaches, the medical team, the family.
Wow, that's a lot to consider.
It is. It's essentially an ecosystem of prevention, acknowledging that many factors conspire to cause overuse, and effective prevention requires addressing as many of them as possible in a coordinated, integrated manner.
An ecosystem of prevention. I like that phrasing. It makes perfect sense, given the complexity. Are there any other broader contextual factors or specific risk factors highlighted in the source that are particularly important, perhaps for specific groups of athletes?
Yes, two key areas are given special attention in the material. Firstly, growth and development in adolescent athletes. The source emphasizes that periods of rapid growth during adolescence are critical windows of vulnerability.
The teenage growth spurt.
Exactly.
Yeah.
During these growth spurts, bones are lengthening rapidly, muscles and tendons may become relatively tight compared to bone length, and coordination can be transiently impaired. Applying intense training loads during these phases can place excessive stress on still developing musculoskeletal structures, significantly increasing the risk of repetitive microtraumatic injury. Things like apophysitis, which is inflammation or stress injury at growth plate attachment points, or bone stress injuries. The source really stresses the importance of monitoring not just chronological age, but crucially maturational age, their biological development stage, when planning training loads for young athletes.
So you need to treat them based on their development, not just their birthday.
Absolutely.
Hmm?
Secondly, and arguably one of the most important and often overlooked risk factors discussed, is energy availability. The source introduces the concept of low energy availability, which occurs when an athlete's energy intake, the calories they consume, is insufficient to meet the demands of their training and other essential physiological processes.
Not eating enough, basically.
It can be that simple, yes. And importantly, this doesn't always stem from intentional disordered eating. It can be entirely unintentional, simply failing to consume enough calories to fuel very high training loads. This leads to a condition called relative energy deficiency in sport, RDS.
Ready, yes, I've heard of that.
Yes, it's a syndrome that impairs numerous bodily functions beyond just performance. It affects metabolic rate, menstrual function in females, bone health, immunity, cardiovascular health, the list goes on. REDS is presented as a significant, often missed risk factor for injury because it fundamentally compromises the body's ability to recover, adapt to training stress, and maintain tissue health, particularly bone health. The source highlights that adequate fueling is absolutely fundamental not just for optimal performance, but for maintaining overall health and resilience against injury. It's a systemic issue that can manifest locally as an injury.
That point about low energy availability acting as a systemic underlying issue that makes someone vulnerable to a local injury is really profound, isn't it? It shifts the focus from just the mechanics of the injury to the body's overall fuel and repair capacity. We've covered a vast amount of detail here, from tissue science right through to systemic risk factors. Let's maybe do a quick lightning round on a few specific practical points mentioned in the source. Beyond activity modification and structured rehab, what are some of the more specific non-surgical or perhaps adjunctive treatments mentioned for common overuse issues like chronic tendinopathies or bone stress?
Okay, well, for tendinopathies, the source mentions approaches like biomechanical analysis and correction. That could involve things like prescribing specific shoe inserts or exercises designed to improve muscular stabilization patterns, aiming to alter load distribution through the tendon. Shockwave therapy is also noted as having some evidence, with peroneal tendinopathy that's on the outside of the ankle given as an example.
Right.
For bone stress injuries, protected rest and very gradual loading are really the primary treatments. The source is quite cautious about certain biological therapies, things like PRP, platelet-rich plasma, or activegin injections. It states there's currently a lack of high-level evidence for their efficacy and safety in acute muscle injuries, and it implies similar caution for their use in chronic tendinopathies or bone stress, suggesting more research is definitely needed before they can be considered standard care.
Okay, so the evidence base for some of those newer therapies is still developing, it sounds like. The source stresses the importance of a multidisciplinary sports science and medicine team, often coordinated by a case manager. What's the fundamental value of this team-based, coordinated approach? Why is it so important?
The value of the multidisciplinary team, perhaps with a designated case manager, is really in integrating expertise across all the different relevant domains: medical, physiotherapy, strength and conditioning, nutrition, psychology, biomechanics. The case manager acts as the central point of communication, ensuring everyone involved with the athlete themselves, the coach, all the support staff is aware of the diagnosis, the treatment plan, the progress being made, and the criteria for return to sport.
Keeping everyone on the same page.
Exactly. They communicate this plan clearly to the athlete and coach. They help manage external pressures. They facilitate education for the athlete. And importantly, they foster athlete autonomy in the whole process. This coordinated approach is absolutely essential for navigating complex injury management and ensuring a consistent, evidence-informed pathway back to performance, preventing things like conflicting advice or missteps along the way.
Finally, any quick takeaways on how training intensity versus volume relates to injury risk, building on that idea of optimal loading we discussed?
Yes, the source touches on how training approaches evolve. For example, it mentions the trend towards higher intensity, perhaps lower volume work for power development and speed disciplines, versus the more varied intensity and volume approaches often seen in distance running. The key takeaway related to injury, I think, is that both intensity and volume must be carefully periodized and managed in concert with recovery to stay within the athlete's adaptive capacity. Pushing either variable too hard, too fast, or crucially without sufficient recovery is a primary driver of overuse injury. Understanding the athlete's individual response to specific types of load is really paramount.
This deep dive has been incredibly illuminating, really pulling back the curtain on the science of performance breakdown and recovery in elite athletes. Let's try and distill some key takeaways from all this source material.
Good idea.
Firstly, I think, is to recognize that overuse injuries are the dominant challenge in high-demand activities. They often stem from gradual, insidious processes like tissue degeneration, that tendinous idea, or bone stress reactions, which require different management approaches than simple acute inflammation.
Definitely key.
Secondly, successful performance and injury avoidance seem to hinge on prioritizing optimal loading and recovery. Understanding the different adaptation and healing rates of various body tissues, that heterochrony concept, seems crucial to build resilience without causing that cumulative damage.
Spot on. That balance is everything.
Thirdly, making those high-stakes return-to-activity decisions is clearly complex. Don't rely solely on imaging, which we learned can be misleading. Instead, integrate clinical signs, functional readiness, psychological factors, and an assessment of risk tolerance, maybe using structured frameworks like START.
Yes, a much more holistic view is needed there.
Fourthly, effective injury prevention, or perhaps avoiding professional burnout by analogy, is a multimodal, multifactorial challenge. There's no single magic fix. It requires a holistic approach addressing physical capacity, technique, lifestyle, psychological factors, and coordinated support across a whole team.
The ecosystem approach, as you called it.
Exactly. And finally, perhaps pay close attention to those systemic factors like low energy availability or REDS, which can be a significant underlying risk factor for injury and compromised performance. It really highlights the fundamental need to fuel adequately for your demands, whatever they may be.
Absolutely fundamental.
This exploration into the world of track and field injuries offers some really powerful parallels, I think, for anyone navigating the pressures of a demanding professional life. The principles of managing cumulative stress, respecting the body's varied recovery needs, understanding the limits of diagnostics, and adopting a holistic approach to maintaining well-being feel pretty universal.
You certainly do.
If you found this deep dive valuable, please do take a moment to rate and share the show so more professionals can benefit from these insights. Professor Moimam, thank you so much for guiding us through this complex source material with such clarity and really valuable insight today.
It was my pleasure entirely. Understanding these mechanisms is, I believe, key to sustainable high performance, wherever that performance happens to take place.
Indeed, and it leaves us with a question to perhaps ponder. How consciously are we applying these lessons about cumulative load, heterogeneous recovery, and multifactorial well-being to ensure our own sustainable performance and health in our daily professional sprints and marathons? Something to think about until our next deep dive into the source material.